Thank you very much, everyone, for coming tonight and giving me this option to give the talk. And thank you so much for the nice introduction. When I was planning to come to Winnipeg, I really didn't think that I'm going to be this happy by coming back to Winnipeg and seeing all the friends and my supervisor, who is more like my mom. So, I mean, I was here like less than a day so far, and it was a great pleasure. And I'm so happy. So that's good. Even though it's snowing and it's much colder than Toronto at the moment, but I really didn't feel that. So what I'm going to talk today is just briefly about what I did during my PhD and where is the base of me and what I did under the supervision of Azadeh and also Maggie Yunus, who is here. And then how I continued that into my postdoc at the University of Toronto. So first of all, I really like to thank all those who helped me a lot during this journey. First of all, my mentors at the University of Manitoba, Professor Azadeh, Maggie Yunus, and also Professor Yadollahi, who helped me a lot and taught me a lot in what sleep apnea is, and also how to be a researcher. And also my advisor at the University of Toronto, Professor Bradley and Jeff Burnley. And my advisor also at Harvard University, I spent about 5 months in his lab, Professor Jeffrey Frederick. Also, I'm really thankful to all the friends and colleagues who helped me a lot with my research, who helped me in terms of the scientific support and the analysis that we did, both here and at the University of Toronto, and also to the technical support that I got from the sleep lab here at Misericordia Hospital and also at the University of Toronto. We did a lot of experiments, many of them were at night, and without their help and support, it wasn't impossible to run any of those experiments. And definitely, I'm so thankful to all the volunteers. As I have said, most of what I did is related to the sleep apnea. And just briefly introducing what the sleep apnea is, sleep apnea occurs due to the cessation of airflow to the lungs during sleep. There are two main types of sleep apnea. It can be either obstructive sleep apnea when the airway collapses during sleep. For example, because of the gravity that pulls the airway together and collapses out. Or you know that the muscle tone decreases during sleep and that can contribute to the collapse of the airway during sleep. Or if someone is overweight and there is more fat and tissue around the airway, that can contribute to the collapse of the airway during sleep. The second type of sleep apnea, which is less common, is called central sleep apnea. And usually it happens when there is the right ventilatory drive from the nervous system doesn't come. So there's no problem in the airway by itself, but the command for the respiration doesn't come from the nervous system. And one of the reasons that can cause central sleep apnea is when the level of CO2 goes down in the blood. So the brain thinks that there is enough oxygen in the system when there is not enough. So it decreases down the level of the ventilation, and that causes central sleep apnea. Sleep apnea is a common problem. It affects more than 10% of adults. And because of all those drops in the blood oxygenation level during the sleep as a reduction of the airflow, it's associated with several cardiovascular disease, neurodegenerative diseases, and it increases the risk of stroke, cancer, and also it causes excessive daytime sleepiness in patients who have sleep apnea and who are not treated. Only in the United States, sleep apnea costs about more than $65 billion annually, and the cost of sleep apnea are increasing because the population ages more, the population becomes more obese and also more sedentary. The gold standard to assess sleep apnea is called polysomnography. So the patients go to the sleep lab, stay there for a night, and more than 15 different physiological signals are being recorded to monitor the breathing, the EEG signal to know the sleep pattern, and also the physiology, the structure of the sleep. And you can assume that it's expensive, it's not convenient, and there's a long waiting list for the patient to get to the sleep lab. The way that they assess that is they find if there is any complete reduction in the airflow, which we call it apnea, and it should last for more than 10 seconds, or the amount of airflow reduces to less than 50% of its normal amount, which is called hypopnea. And it should be associated with a drop of at least 3% in the blood oxygenation level, or it should be associated with an arousal from sleep. And then they count the number of apnea and hypopneas per hour sleep, which is called apnea-hypopnea index, or AHI. So that's like the main outcome, or one of the main outcomes from the full night polysomnography. Now the main challenges, or two of the main challenges in the management of sleep apnea that we were trying to answer during my PhD was the underlying mechanisms of the upper airway collapse are not fully understood. We don't know what exactly causes sleep apnea in different populations. So we're trying to see if we can develop new techniques to identify the underlying mechanisms of sleep apnea, and that's one of my main interests. Also, because PSG is very expensive and there's a long waiting list of patients, and more than 90% of patients with sleep apnea are not getting diagnosed, it's important to develop simple, more accessible, and more affordable devices for portable monitoring of sleep apnea. So these are like the two main things we're trying to focus on. And the system that we developed and the techniques that we were working based on were related to the respiratory sound analysis. So when the airflow goes or passes through the airway, what happens is that passage of the air causes turbulence of air within the airway, and it can generate respiratory sounds. And the energy of the sound is related to the flow to power alpha. So this is what we did in 70 healthy subjects during wakefulness. We recorded tracheal sound with a microphone over trachea. And here is a sample of data recorded over time for about 2 minutes. And this is the airflow which was recorded simultaneously. And you can see that when flow is increasing, the energy of the sound is increasing too. So we use this to estimate the airflow from only tracheal sound. And you can see how nicely the estimated airflow can follow the change in the recorded airflow. We also tried this in patients when they were asleep, and we showed that our method can estimate airflow from only tracheal sound with accuracy of more than 90%. Then we expanded that method to see if we can detect sleep apnea, if we can detect the apnea when there's no breathing airflow, or if there's any reduction in the airflow. And we developed a device for acoustic sleep apnea diagnosis, and this is the device that we patented. We recorded tracheal sound with the same microphone, the same thing, and at the same time we use a pulse oximeter to record the level of the oxygen in the blood. We test our system and our method and data of 66 patients at Misericordia Hospital here at Winnipeg, and at the same time we are recording full night polysomnography as the gold standard. And what you can see here, each data point is the apnea-hypopnea index of one patient. The horizontal axis shows the gold standard AHI based on the full polysomnography. And the vertical axis shows the AHI based on our acoustic system. And we found a high correlation of 0.96 between the two systems, showing that we can use sound and pulse oximetry to detect sleep apnea, beside all these signals that we're recording. We also did some other studies to see how we can use the relationship between the respiratory sounds and the airflow to know more about the change in the anatomy of the airway and in the physiology of the airway, for example, how it's changing in patients with sleep apnea or healthy subjects from wakefulness to sleep. And that I didn't show here because just for the sake of time, but we can discuss this later if you're interested. So these results all together are as a proof of concept showing that the sound analysis can be a powerful technique to get more information about the upper airway, what can cause a sleep apnea, or what are the factors that contribute to the sleep apnea in terms of the upper airway anatomy and physiology. And then, as I was interested in the airway and the sleep apnea, when I moved to Toronto, I started working with a group who are focusing on sleep apnea, but the idea that they have in the group, in this group, is based on something called rostral fluid shift. So the idea is, when we lie down to sleep, the fluid which is accumulated in the legs is moving out of the legs to the upper body, to the chest and neck. And that contributes to the sleep apnea severity. So what I will do in the rest of this discussion is just to give a review of what they did before I go to the lab about the fluid shift and its role on the sleep apnea. And then the two other parts of the talk will be about 2 experiments that I did in the lab to see what is the pattern of this fluid shift or fluid redistribution to the upper body, what's the time course of these changes, and how it's different between men and women. And the reason that we're interested in the effects of sex is because we know that sleep apnea is more common in men compared to the women. I also did another experiment to see if the fluid is really affecting the sleep apnea, can be fluid overload patient and induce sleep apnea, so, as a proof of concept. So these are the 2 main studies that I'm going to discuss later. We know that if someone is more overweight or more obese, there is a higher chance of getting sleep apnea. But neck circumference and BMI together account for only about 30% of variability in AHR. And at the same time, we know that the prevalence of sleep apnea is more in patients with heart failure or with renal failure. And these are the conditions which are associated with fluid retention. So these patients are usually fluid overloaded compared to the general population. And if you look at the heart failure patients, in general, they're less obese than the other patients who have sleep apnea. So it's not only the obesity or being overweight that contributes to the sleep apnea. There should be other factors contributing to the sleep apnea, at least in this population of patients. And assuming, consider airway as a bony enclosure that the airway is within that, and we have the pharyngeal tissue around the airway. So if there's more edema, more fat, or more fluid in that pharyngeal tissue around the airway, for example, in the case of that happens in the sleep apnea, then there will be more increase in the pharyngeal tissue pressure that impinge on the airway and causes narrowing of the airway. And edema can contribute to that. So the idea that was developed is during the day, because of the gravity and because we usually sit and we don't have that much of activity, fluid will accumulate mainly in the legs. And at night, when we lie down and there's no gravity anymore, the fluid will redistribute out of the legs to the upper body and gets into the neck or to the lung. Now, the part of the fluid that gets into the neck may narrow the airway and cause more obstructive sleep apnea. And the part of the fluid that gets into the lung may cause more pulmonary edema, more congestion in the airway, in the lungs, and then stimulate the receptors within the lung. And if those receptors being stimulated, what happens is that they hyperventilate, they increase the amount of ventilation, and they decrease the level of CO2 below the apnea threshold, and causing central sleep apnea. And this is what happens in patients with heart failure. So I'm not saying that this is happening in everyone, but in patients who may get pulmonary edema as this excessive fluid, they may get central sleep apnea. So what the group did was they measured leg fluid volume overnight, before sleep and after sleep, and I talk more about how they did those measurements later on. But here, this graph shows the change in leg fluid volume from before sleep at night to the morning. So the more means that more fluid is coming out of the leg. And with the more fluid coming out of the leg, they showed that the neck circumference increased more. So it's probably accumulating more in the neck. And at the same time, in the same population of non-obese men, they found that the change in the leg fluid volume was strongly associated with the increase in AHR. So with more fluid coming out of the legs overnight, they had a higher AHR. They also found that the amount of fluid which comes out of the leg overnight was strongly associated with the amount of time that the subjects spent sitting during the day. So the more sedentary the lifestyle is, the more fluid will be accumulated in the legs and more fluid will come out of the legs at night. They also looked at the effect of fluid shift in patients with heart failure. So, in a group of patients who have mainly obstructive sleep apnea, they found that again, with more fluid coming out of the legs, the neck circumference increases more. However, in those patients who have mainly central sleep apnea, again, the same relationship exists, but with another, the curve is different. And what is interesting is that, for example, if you look at the same increase in neck circumference overnight, the amount of fluid which is coming out of the legs is higher in those with central apnea. So there is more fluid coming out of the legs over the night. It's the same amount of increase in the neck circumference. So part of the fluid should go somewhere else. It can be that the fluid would accumulate in the lungs and cause pulmonary edema. And to test that, they measured the CO2 level during the sleep. This is the relationship between the amount of fluid coming out of the legs and the CO2 level in patients with heart failure and obstructive pneumonia. And there was no relationship between CO2 and leg fluid volume. But in those who have central sleep apnea, the more fluid coming out of the leg, there was a negative relation with the CO2, meaning that there was a more decrease in the CO2, so they had more hyperventilation. So probably there was more fluid getting into the lung, causing pulmonary edema, causing hyperventilation, and decreasing the level of CO2 and causing central sleep apnea. And again, in both groups, the amount of fluid coming out of the legs was related to the apnea-hypopnea index. So to summarize these results, during the day, because of the inactivity, fluid will accumulate in the legs, and at night, the fluid coming out of the legs will either get into the neck or into the lungs. And depends on where it goes more, it can contribute to either obstructive sleep apnea or central sleep apnea in heart failure patients. The other thing that, the group was interested was, as I said, sleep apnea is more common in men compared to the women. And they wanted to see how sex is affecting the pattern of fluid redistribution. So in the same group of patients with heart failure, they found that in men there is a strong relationship between the amount of fluid coming out of the leg and the increase in neck circumference. However, such relationship didn't exist in women. Also, it was only in men that the fluid which was coming out of the leg was related to the apnea-hypopnea index, but not in women. So what they found was that for similar amount of fluid coming out of the legs overnight in men and women, the change in leg fluid volume out of the legs was strongly related to the increase in neck circumference and also to the apnea-hypopnea index, only in men but not in women. So they hypothesized that probably part of the fluid that comes out of the leg should go somewhere else and not get into the neck, and decreases the chance of sleep apnea in women. And what we thought was maybe the fluid is getting into the abdomen, because we all know that women has the more venous plexus in the abdominal region in their pelvis because of the pregnancy, and to be able to have that protective mechanism during the fluid overload that happens during pregnancy. So we're interested to see if fluid is accumulating in the abdominal region in women more than men, and that's one of the mechanisms that contribute to the lower sleep apnea in women compared to the men. And this is the first experiment that I'm going to talk about based on this, to see what's the pattern of fluid redistribution out of the legs. Because all that my group did so far was just, they were only able to measure the leg fluid volume only before and after sleep. And they were only able to measure the fluid at the leg. So they don't know where the fluid really goes and what happens, really, if it really goes to the neck or to the chest or to the abdomen. And also they don't know anything about the time course of they didn't know about the time course of the changes. How long does it take for this fluid to be redistributed, or does it get to any plateau or not? So for this experiment, our hypothesis was for similar amount of fluid displaced from the legs while supine, women will accumulate more fluid in their abdomen, and consequently in men, more fluid would reach the neck and chest than women. And this is the system that they developed for measuring fluid in various body segments. And it's based on the bioimpedance. So we know that the interstitial fluid is the conductance of electricity because of all the ions that that compose the fluid. So if in one segment there is more fluid, then the impedance of that segment will be less. So what we do is we measure the fluid. There are for each segment there are 4 sensors. 2 of them are injecting a high frequency low amplitude current, and the other 2 segments are measuring the voltage. So by measuring the impedance of that segment and knowing the shape of the segment in terms of the circumferences and length of the segment, we can estimate the amount of fluid volume in that segment. So we simultaneously recorded fluid volume in leg, abdomen, thorax, and neck. We had 40 subjects who participated in this study. They lay supine for 90 minutes. And at the beginning and at the end of the study, we recorded neck circumference. And every 15 minutes, we measured the size of the upper airway cross-sectional area with acoustic phagometry. We also simultaneously recorded tracheal sound from these subjects. We had 20 women and 20 men who participated in the study, and the neck circumference was smaller in women compared to the men. And the baseline fluid volume in the 4 segments were lower in women compared to the men. And this graph shows the change in leg fluid volume over time. So here is the horizontal axis shows time in hours, and we recorded data for an hour and a half. The vertical axis shows the change in leg fluid volume from baseline, from time 0. The red ones are in milliliter. This is only for one leg. The red dots are showing the data report, the average of data in women, and the blue dots are showing the data in men.
Sorry, question. The y-axis, the change in fluid volume, is that calculated for both legs, all the legs, or is it just a representative?
This is only for one leg. But there were other studies that we measured the fluid volume in 2 legs, and it's all. Most of the cases.
It's in the whole leg. It's not just in a compartment.
No, it's whole leg. So it's a start from the top of the thigh here. The highest that you could go until up to the ankle.
Okay, but you're measuring only in a few points. You're not measuring the impedance everywhere.
But the impedance that we measure is for the whole point.
For the whole leg?
Yeah, because it measures the voltage from here to here, so it considers the impedance of the whole leg.
Of the whole leg.
Yes, sorry, it wasn't clear. But it's for one leg.
Right. But the data you reported before about fluid shift from the legs and AHI and all that was calculated for both legs?
I'm pretty sure that they did measure for one leg and multiply it, assuming that it's the same amount.
But multiplied by 2?
I'm pretty sure that's what they did.
But it's just very difficult to imagine how 250 mLs, 300 mLs shifting from the legs and distributed everywhere would cause all these problems, like increasing the size of the neck. This is just like a cup of water.
It is.
It's hard.
And it's not that all of that will get to the neck, definitely. When I show the data of the neck, the change in the neck fluid volume will come after this is even less that. But then, yes, there was another study that's not here, we can discuss this later, but then we reported the size of the jugular vein at the same time with the ultrasound, and we showed the relation between the 2 of them. So it's increasing definitely not even the whole of that good one cup is getting there, but it's there's a very nice correlation between the amount of fluid which is getting into the neck and the increase that we have in the neck circumference. So, in both men and women, the change in leg fluid volume was similar after 90 minutes. And we tried to model this with an exponential model, and we found that using an exponential model for the change, first of all, it's an exponential function is a very good model for the change in the leg fluid volume. And even after 7 hours, which is like a typical time of sleep, the change in the leg fluid volume will be similar in both men and women. And here is the data for the abdominal fluid volume. And what we found was that after 90 minutes, the amount of fluid which is there is an increase in the abdominal fluid volume in women, so it's increasing, but it doesn't increase in men. However, the change between men and women, the increase wasn't, it was borderline significant, but it wasn't significantly higher in women compared to men. It can be either because the dynamics of change in the abdominal fluid volume is more complex compared to the leg, and if we had more time of recording, it could have been significant. Or it's just that it's very variable between the subjects, and we have high variation patterns of fluid accumulation between the subjects that we couldn't get to the consistent significant difference between genders. However, when we look at the change in the thoracic fluid volume, what happened was that based on both the recorded data and again the simulated data based on an exponential model, men accumulated more fluid in their thorax compared to the women. And the same happened to the neck fluid volume, which shows that after 90 minutes and also with simulating the data after 7 hours, men would accumulate more fluid in their neck compared to the women. And here is how the change in neck fluid volume is related to the change in neck circumference. So that's the data from all the subjects. And what we found was that with an increase in neck fluid volume, there is a strong relation with the increase in neck circumference. So more fluid which is accumulating in the neck, causing more increase in the neck circumference. We also looked at the change in neck circumference and the size of the airway within each group and between men and women. And we found that after 90 minutes, in both groups, neck circumference increased. And the increase in neck circumference was bigger in men compared to the women, and it was significant, which complies with our data that there was a bigger increase in the neck fluid volume in men compared to the women. It was only in men that the size of the airway decreased, however, it wasn't significant compared to the women. So based on that, and because we also were interested to see if fluid accumulation in the neck increases the size of the, narrows the airway and changes the anatomy of the airway, and probably increases the collapsibility of the airway, so change the structure of the airway. And we use the tracheal sound to estimate the absolute values of neck fluid volume. So what we did was we recorded tracheal sound simultaneously with the fluid data. And we used two methods based on our regression and neural network. First of all, to find the most significant features that change with the increase in neck fluid volume, and also to estimate the absolute values of neck fluid volume. And here is a sample of data that we reported. So every dot here shows the neck fluid volume for one inspiration. And the blue dots are showing the data which was recorded with bioelectrical impedance. And we look at the data at 4 different periods of time because we were just taking a lot of time to manually select all the inspirations. So what we did was we looked at 10 minutes of data at the beginning and at the middle and at the end of the recording, and we see that the recorded neck fluid volume, which is the blue dots, are increasing over the time. From about 199 milliliters to around 209 milliliters. And the red dots are showing the estimated fluid volume in the neck. And the error here is plus minus 1 milliliter. So on the data of 28 subjects that we had with some data, we showed that our error was less than 3% in estimating the absolute values of neck fluid volume using only some features. So to summarize this part, what we found was that in both men and women, leg fluid volume decreased and thoracic and neck fluid volume increased over time. And while abdominal fluid volume didn't increase in men, it did increase in women. And more importantly, after 90 minutes, men accumulated more fluid in their neck and thorax, which was associated with a greater increase in neck circumference in men compared to women. And that can be, as I said, one of the mechanisms that may contribute to the higher prevalence of sleep apnea in men compared to the women. The second experiment is, if really fluid is causing all these effects and more fluid is causing more sleep apnea, what happens if you have subjects without sleep apnea or with mild sleep apnea and you fluid overload them, inject saline into them, and see if you can cause sleep apnea or induce sleep apnea in these subjects. And because all that we've shown so far was that the fluid shift is more effective in men compared to the women, we only included men in this study. And because sleep apnea is more prevalent in men, in the older men, we grouped our subjects based on their age. So our hypothesis was that in older men with non-severe sleep apnea, which means that the apnea-hypopnea index is less than 30, infusion of normal saline during sleep will cause a greater increase in AHI in association with a greater increase in neck circumference and a greater decrease in upper airway cross-sectional area than the younger men. So the study that I implemented was a single-blind, randomized, double crossover study. The subjects came to the lab and slept during the day for this study, and they sleep deprived themselves the night before to measure that they can fall asleep during the day. Before sleep, we measured blood pressure, neck circumference, upper airway cross-sectional area, and then also the full, the complete polysomnography or PSG. For the control arm, there was an intravenous infusion of saline, but at the minimum rate just to keep the airway open and make sure that both arms are the same. During the saline infusion arm, when the subjects fell into the second stage of the sleep, we infused saline at the rate of 22 milliliter per kilogram weight of the subjects, which is roughly about 1.5 to 2 liters of saline for normal adults. And that's the amount of fluid that, for example, we take out with the dialysis in patients who have at the end stage renal disease. And our subjects were wearing compression stocking to make sure that the fluid won't accumulate in the legs, and we cause the fluid overload in the upper leg. After the sleep, we repeated the measurements of blood pressure, neck circumference, and upper airway cross-sectional area. And after 1 week, the subjects were randomized, were crossed over to the other arm of the study. So every subject participated in the both arms. We have 17 subjects who participated in this study. We had more than 50 subjects who were included in the study. Some of them didn't pass the screening test. Some of them didn't have apnea-hypopnea index of less than 30. During the control, at the end, we had 17 subjects that finished both arms of the study, and some of them couldn't fall asleep during the day. And here's the data for the younger group and the older group. And although we were trying to get subjects without sleep apnea, our older subjects had mild sleep apnea. And here is the effect of saline infusion in the younger group. So this is the data after control arm of the study, and here's the data after intervention of saline infusion, and these are the statistical analysis. Sleep efficiency decreased in the younger group, and we also measured the change in the blood pressure from before sleep to the after sleep, which didn't increase in the younger group, or there was no change in the heart rate. The upper airway cross-sectional area didn't change significantly, but the neck circumference increased in the younger group. However, the apnea-hypopnea index didn't increase in the younger group. So during both arms of the study, the apnea-hypopnea index was about 8 and then to 10. Although we injected about 1,800 milliliters of saline to the younger group. In the older subjects, we did the same thing. We almost induced the same amount of fluid into the older group. There was an increase in the blood pressure, but the change were not significantly different from the control arm. And there was an increase in the neck circumference like the younger subjects. However, in the older subjects, the AHI increased from 16 to 48. So we had a threefold increase in apnea-hypopnea index with saline infusion. Also, when comparing the effects of only saline infusion between the older and the younger group, what we found was that in the younger group with saline infusion, there wasn't an increase in the blood pressure from before sleep to the after sleep, but in the older group, there was about 11 milliliters of mercury of increase in blood pressure, which was significantly higher than that in the younger one. The neck circumference increased more in the older group, and also the change, the AHI was significantly higher in the older one compared to the younger one. And this is the details of data in the two